create possible. Together we create possible.
Welcome everyone to today's episode of the Young Epilepsy podcast. We're here today to discuss the connection between epilepsy and mental health for children and young people, from the challenges they face to the support available. Before we jump in, we'd like to take a moment to thank our sponsor. For over 25 years, Nutricia Ketogenics has been dedicated to supporting patients with drug-resistant epilepsy. Their extensive range of ketogenic medical foods is designed to simplify the ketogenic diet for both adults and children living with epilepsy, as well as their families. For those with refractory epilepsy, a ketogenic diet can offer a promising path forward. Our supporters do not influence the Young Epilepsy podcast. Creation of topics, guests, and questions are led by Young Epilepsy and our community. Epilepsy isn't a mental illness, but young people with epilepsy are 4 times more likely to face mental health challenges. There are 3 main reasons for this. First, the underlying cause of epilepsy can contribute to mental health problems. For example, if you have an injury to the brain that controls mood, that can lead to difficulties with mood and well-being. As well as that, hormone fluctuations, especially during puberty, can also affect mood and seizure frequency. As well as this, anti-seizure medications, whilst crucial for controlling seizures, can impact mood, and that can be both positively and negatively. And lastly, living day-to-day with epilepsy can be tough. Navigating childhood, puberty, and becoming a young adult is challenging enough. But when you add in a condition that's often frightening, unpredictable, and sometimes stigmatised, it can lead to anxiety about personal safety, education, and future career prospects. So here at Young Epilepsy in 2021, we started the On Top of Epilepsy campaign to raise awareness about the connection between epilepsy and mental health. What we really want is we want mental health support to be a part of epilepsy care for young people. And the main reason for this is that we ran a survey that showed that over 3/4 of young people said that epilepsy had a big impact on their mental health. But right now we know that less than 1 in 5 epilepsy clinics offers mental health support. So we started our campaign and we put out a petition asking UK healthcare leaders to make sure that all children and young people with epilepsy get mental health checks and support. And we got over 10,000 signatures on that petition. And since then, we've been working with the NHS to find ways to improve support. In England, we've come up with recommendations to make mental health checks and support part of children's epilepsy care, and pilot projects across the country are now being funded to test how that can work. We've also talked to representatives from the Scottish Government and healthcare professionals in Northern Ireland. And on top of all of this, we've offered our help to improve mental health services for kids with epilepsy in Wales. So we're thrilled to be joined by 3 guests. Perhaps we can go around, first of all, to introduce ourselves. Richard, perhaps we can come to you first.
Hi, I'm Richard Brown. I'm a paediatrician in Cambridge. I've been looking after children and young people with epilepsy for 25 years now. And I'm the chair of the Open UK National Confederation of the Regional Epilepsy Networks. So basically what we try to do is improve the quality of care that children and young people get when we're looking after their epilepsies.
Fantastic, thank you. And Morgan, perhaps we can come to you next.
I'm Morgan from the Young Voice Network. I'm currently studying French and Spanish in my first year at university.
Amazing, thanks so much. And Ingram?
I'm Ingram Wright. I'm a clinical psychologist, paediatric neuropsychologist. I'm based in Bristol. I qualified in 2000, so slightly less experience than Richard, but I've been working in epilepsy since that time. And we now work in a regional neurosciences centre with an epilepsy surgery programme. And my most recent experience in, I suppose, in this space around mental health has been chairing a group that was appointed by NHS England to look at how we can improve screening and delivery of mental health care for young people with epilepsy.
Fabulous, thank you. So thanks again all so much for joining us. We're going to move through a number of different topics today, but a good place to start, I think, might be to hear from you, Morgan. So I wonder if you can tell us a little bit about yourself and your journey with epilepsy.
So I've had a very complicated journey with epilepsy. So I had my first seizure when I was 1.5. Then I got diagnosed when I was around 5 years old. So it was a very lengthy process. Then I got my diagnosis taken away when I was around 8 years old, and they thought that I had grown out of my epilepsy and that it was sort of childhood epilepsy. And then when I was 13 years old, I had a seizure again at a friend's birthday party. It was about a month after I turned 13, and it was kind of a real shock. You know, I didn't expect to have another seizure again. So ever since then, I've had seizures. I just turned 19, basically. But you know, in between then as well, I also have had testing done for non-epileptic seizures, and I've had, you know, trouble with you know, getting diagnoses for that, like misdiagnosed for that, and having like neurologists question me for that, even though I had tests that showed that I was epileptic. So I've been on a real journey with my epilepsy.
Absolutely, it sounds like it. And are you still having, is it still ongoing, the process? Are you still trying to work out what's causing the seizures and things like that?
So they don't know what causes my epilepsy. As I said, I've just basically had them pretty much ever since I was a baby. But it is confirmed I do have epilepsy now. I don't have any non-epileptic seizures. But yeah, it's been a long journey, and I still have seizures. I'm around 6 months seizure free now, which is the longest it's been since I got diagnosed again at 13. So, you know, fingers crossed that it'll continue that way. But yeah.
And are you currently taking any? Do you take anti-seizure medications for your?
Yeah, I do. I take 2. I take lamotrigine and I take topiramate. But I've tried a lot of different medications. I've tried about 5 different medications since I turned 13. So it's been a big struggle to try and get me to even 6 months seizure free. And when I was around 16, 17 in year 12, there was a stage where I was having like around a seizure every week, seizure every 2 weeks, and that was a really difficult time.
Yeah, I bet. It's a tricky age as well, isn't it? So in terms of your mental health, how do you feel that epilepsy, I can imagine all of that is really challenging. So how do you feel that epilepsy and your epilepsy journey has impacted your mental health?
Well, as I said, especially when I was going through that stage when I was around 16, 17, I was having those every 1 or 2 weeks when it was really uncontrolled. That was probably one of the worst times, because, you know, everyone around me was starting to get like their driver's licenses, things like that. You know, that's sort of the age, you know, when you go into like college, sixth form, where everyone definitely becomes more independent. They were starting getting, you know, jobs, things like that, and I really started to feel more left out on that type of thing. And, you know, I felt more isolated. And then the same type of thing happened when I was around 14, 15, and I was like going through my GCSEs, and it was a really stressful time, you know, having that sort of exam pressure all upon you, and, you know, going through trying to manage your seizures whilst also having to juggle your exams and things like that. But, you know, the people around you not necessarily knowing how to help, especially like staff at school, you know, not really having the training to do that. It's really complicated because sometimes you feel like you're having to deal with it alone. And even people around you that want to help, like friends or family, they can help you as much as they try and want to, but they don't necessarily always know exactly what you're going through.
Yeah, absolutely. How was it at school? Did you feel like they understood the things that you needed?
They tried to. The school definitely tried to. My school was pretty good to an extent. You know, they offered me, you know, like in-school counselling when I was going through like a rough patch when I was around in 9 for my seizures, like year 9, 10ish. I sort of after COVID, because I knew that I was struggling with my exams and things like that. But also, sometimes they weren't actually great with like when I had a seizure in school. You know, my friends were really good when I had seizures, because I did have seizures in school, but they directed, obviously there's things that they have to do, you know, in terms of procedures, but sometimes I found that the first aid medics were actually really, really poor in terms of their seizure training. You know, my friends were really well versed in what to do when I had a seizure in school, and there was this time I had one in maths, and my friends had, you know, put things under my head and, you know, ended up taking my glasses off, got me into the recovery position and everything. And this was before the first aider had arrived. And when the first aider arrived, he had, you know, kicked them out of the class and everything. But he had not known what to do with like the thing under my head, and he had taken it off my head and things because he thought it would like make me suffocate because of the coat under my head. But, you know, it was stopping me from like hitting my head and everything. So when you find out things like that, it made me really angry, because it makes you realise how like little people actually know about like dealing with epilepsy. So things like that, when you realise like the misconceptions that people have about epilepsy and how little they know, it makes you kind of really worried and anxious and angry. And that's one of the things that I felt like I dealt with a lot at school, when I realised how little the people around me knew about the condition.
Yeah, especially I suppose when you're somewhere where you're supposed to feel safe and you're supposed to feel like these people, they have the knowledge to support you. I can imagine how that can be scary.
Yeah, definitely.
Yeah. So you mentioned the school offered you some counselling services. Have you been able to access any other support throughout your journey?
Yeah, so as I said, at one point I was under investigation for non-epileptic seizures, and the hospital at that time, they did refer me to like CBT counselling because of that, because they said, you know, non-epileptic seizures are sort of like caused by stress and things like that. But that was the only time that the hospital had ever considered giving me any type of mental health support as a result of my seizures and things like that.
So never to support you with the epilepsy diagnosis necessarily?
No, never. You know, after that diagnosis or that investigation got taken away, they never gave me any type of mental health support because of it. No.
So, I mean, you sound like you've found really good like ways to cope with it yourself, given you're kind of at university and all of these things. Is there any particular things you've found that you've found helpful?
I think it's really important to talk to the people around you about it and educate them. It's not just about talking to them about it and like you can't just talk to them about it and tell them I'm stressed. You have to really tell them about it and let them know what you're going through and what it's like to have epilepsy. It's a conversation that has to be ongoing. But in terms of things that, you know, you have to do when you have epilepsy, you have to find things that you enjoy, because it's not practical always to say, oh, I like to go out, I like to do this and that, because, you know, especially for me when I was going through a rough patch of seizures, it wasn't always something that you could enjoy, you know, but I found that it was good to find things that you could do inside the house. You know, it was good to read, to find like movies that I like to watch. It was good to, you know, call my friends, which is why I said it's good to make sure that you have that connection with people. But when my seizures got better, I did like to go out with my friends. I liked to, you know, you just have to find what really works for you, because it depends on your epilepsy, it depends on what type of person you are. Everyone is individual, and I think that's really important to stress.
Absolutely. It sounds like your friends have been a great support.
Yeah, definitely.
Yeah, that's amazing. Is there anything that you wish you knew, so anything you know now that you wish you'd known when you first started struggling with epilepsy or struggling with feelings of isolation or anything like that?
I think I probably wish that I'd known that sometimes it can be a really long journey. Sometimes it could be a really short journey, but it can get better, and it's important based on the people that you have around you, and things will take time. Sometimes things will take time, and you have to acknowledge that.
Given your experiences with mental health, is there anything you'd like to see in the way that mental health is, any improvements you'd like to see in the way that mental health is currently provided to young people with epilepsy?
I'd just like to see more help implemented in general for people with epilepsy. When I got re-diagnosed, it was a real big stressor for me because, as I said, I didn't think that I would ever have to go through that process ever again. And I felt anxious and scared, and I didn't know what the next step was going to be for it. And so I can't even imagine what that type of feeling would be like for someone who's never had seizures before anyway, or gone through that type of thing, because, as I said, I had them as a child. So, I was already used to, the doctor's appointments and, ambulance rides and medications and things like that, because I went through them as a little kid. It was kind of just getting used to them over and over again and, reliving it as a teenager. But so to just completely experience that new, and, it's really important, I think, to have mental health support implemented right from the very beginning. And so I would like to see that for all children and young people right off the bat.
Yeah, it's almost like a standard, I suppose. Yeah. Because receiving the diagnosis is obviously scary.
Very
and all
scary,
of those things.
yeah.
Yeah, absolutely. I completely agree. Are there any, obviously we have 2 experts here with us today. Are there any...
Well, 3. Actually.
3 experts here with you, as well as yourself. Do you have any questions for them, given their work in psychology and epilepsy?
I'd just kind of like to know what's going to happen in the future for people with epilepsy and mental health, like what they're looking into, what's going to be implemented, if anything, like looking at the NHS, the way that the NHS state is at the moment, especially.
I suppose, Richard, my answer to that question would be, I suppose, in terms of what I would like to see. So what I would really like to see happen, the kind of things that you talked about. So I would like to see much better integration of mental health and decent holistic care, so that things get joined up much more. I mean, I think one of the problems with mental health in general is it's been compartmentalised and separated from physical health and other conditions like epilepsy, that we know other young people struggle with asthma and diabetes, and these are complex conditions and they're not without their mental health challenges. But I suppose thinking about epilepsy in particular, the kind of things that you've talked about, the knowledge and expertise that's available in schools, the knowledge that first aiders have about how to respond to a seizure in the classroom. It would be great if all the first aiders in every school in the UK would respond as well as your friends did in that situation. And I think that the more we can do around that sort of more holistic care, alongside the improvements in mental health, I think the more likely it is that people, although there'll be bumps in the road and difficulties in the journey, we can, for most people, start to smooth some of those things out. So for me, it's about the connections between these different aspects: school and home and families having expertise in dealing with mental health, services, paediatricians like Richard. Richard clearly does have expertise in epilepsy, but it's not something that everybody feels confident in dealing with. So I think if we can improve the confidence that people have in understanding epilepsy and mental health, we'll smooth out some of those bumps in the road.
I think the brilliant thing about what you've been saying, Morgan, is that you've brilliantly fertilized this discussion, because your experience kind of completely mirrors exactly what we're told by children and young people across the whole of the UK. The lack of access to mental health services is kind of the biggest priority for our patients. And if you ask the doctors what their biggest priority is, then it's getting better access to mental health care. And you might ask, have people been trying to do anything about this? And you'll be disappointed to hear that the NICE guidance, which is kind of like the sort of the template that we should be working towards, said in 2004 that children with epilepsy should have access to mental health support as a matter of routine. So here we are, pretty much 21 years later, and it's barely in place. To what extent is it barely in place? We looked at this a few years ago, so 3 or 4 years ago, and about 9% of all the paediatric services for children with epilepsy across the country had routine access to mental health care for their patients, which, when you're looking 20 years after, well, about 17 years after national guidance in that regard, is pretty poor. There's all the evidence in the world that we should be doing it. So you mentioned the kind of difficulties that you faced with kind of the feelings of isolation and coming to terms with the new diagnosis, and the sorts of things that children and young people with many chronic conditions would encounter. But we know that those problems with mental health are much more common in epilepsy than in any other chronic health condition. So, more than a third of children with epilepsy have significant difficulties with mental health in that regard, in terms of the problems with it being a chronic health condition. And then on top of that, you've got all of those mental health problems that are more common because epilepsy is a brain disorder. And so things like ADHD, for example, are much more common. So children and young people with epilepsy are crying out for routine access to mental health care. And when we brought together the regional networks, which is all the doctors and nurses that look after children and young people with epilepsy, and there's 14 networks across the whole of the UK, and we brought them together in 2015, just to try and kind of knock on the door a bit harder about this. And what we found is that the vast majority didn't have access to mental health services, and we asked the NHS to pull together what's called the best practice tariff. So to put into the kind of pricing system within the NHS a way of getting a little bit of extra funding for mental health care. And the NHS England agreed to that, but actually no extra funding came with it. So if you look at ever since like 2017, one of the criteria for best practice in epilepsy has been the provision of routine access to mental health care. So it's written in NHS England standards. And yet, several years later, only 9% of units were able to offer it. So we've been trying to do more, and some very clever epilepsy professionals and psychologists in Glasgow pulled together a way of doing routine mental health screening and intervention called the PAVES system, and they showed that was really helpful. So what's happened since then is that NHS England have started piloting this in the 7 different regions of the NHS, of NHS England, actually, not Wales and Scotland. And so there are a few units around the country that are piloting that at the moment. And what that means is that every single patient with epilepsy will be asked about their mental health, and they'll do a questionnaire that sort of, gives a little bit of insight into their mental health. And then depending on how difficult things are for them, then they will get some support through that. So at the moment, that's only a fraction of the units in NHS England that are actually trying that. But obviously the hope is that there'll be more support for all the pediatric epilepsy units to routinely look at asking children and young people about their mental health and then helping them with it.
That's really helpful. I don't know if you have any other questions you'd like to ask Morgan.
No, I don't think so. That was the main one that came to my head. Yeah.
Fantastic. And I wonder if there's anything that you know now that you'd wish you knew when you began struggling with your epilepsy or your mental health.
I wish that I had more coping mechanisms in place. I think it was really difficult for me when I started struggling with my mental health, and probably resorted to not so healthy ones like isolation, shutting away. And that's why I think, as I said, it's so important to make sure you have a support system around you, with friends and things like that. And so that, I think that's why it's so important to make sure that you educate your friends, your family about it, so you make sure that they can know how to support you in a better manner, whether that be, feeling comforted by knowing that they know what to do, whether you have a seizure, so you don't feel as scared or afraid, or whether it be just knowing that you can go to them and confide in them about any struggles that you have in general because of your epilepsy, or anything at all to do with your mental health. That's what I would say.
Thank you. I think it's difficult, what you were saying about coping mechanisms. I think it's difficult to have good coping mechanisms if no one's ever taught them to you. These are the things that hopefully some of the work we're going to talk about today, we can equip young people with epilepsy with kind of better strategies. But I think they're the kind of things that we hope some of this work will teach young people. We don't think that no one knows them automatically. They're not automated. But thank you so much. Thanks so much for sharing all of that. That was really great to hear.
Thank you.
Thank you.
So, Ingrid and Richard, I know we're talking a little bit about some of the challenges, or we've alluded to some of the challenges there of integrating mental health into epilepsy care. So I wonder if we can talk a little bit about that. Perhaps we could start by, Richard, I don't know if you could summarise some of your experiences of talking to young people with epilepsy about their mental health and connecting them with the support that is currently available.
Well, I guess there's two levels on which I've spoken to children and young people about this, because there's my kind of everyday clinical practice, and then of course there's the work that I've done through Open UK, working with Epilepsy 12 to talk to children and young people through the Epilepsy 12 youth advocates, who are fantastic group of young people that tell us about their experiences, much in the way that Morgan has done. I think my experience has been that we have lots of problems in our clinical practice to try to fix with problems with mental health, and indeed, full-blown neuropsychiatric difficulties, and that's because the problems with mental health and with neurodevelopment and neuropsychiatric diagnoses are much more common in children and young people with epilepsy than they are in the general population. So, for example, many of my patients have autism spectrum disorders. So we confront the difficulties that anybody would face when diagnosed with a chronic illness. So that just feeling bad about being unwell, worried about what other people will think if they see you having a seizure in school, worried about being isolated, and of course, fears for physical safety and of course for the future. We also have other problems, so increased likelihood of diagnoses of ADHD, of autism spectrum disorders, of anxiety and other mood disorders. And other neurodevelopmental comorbidities as well. So, for example, tic disorders and Tourette syndrome are more common in children with epilepsy. Morgan mentioned earlier on that non-epileptic seizures are a really important thing for us to diagnose correctly. And the reason why non-epileptic seizures are really important to consider is that we can often improve the situation for a child or young person with proper treatment. So getting diagnosis right and putting the right treatment in place is really, really important. Morgan also raises the very important question of accurate diagnosis. So we've had problems with accurate diagnosis in epilepsy over many years, and I think it's probably true to say that we're getting much better at it. And one of the key things about that is not only better training, but the use of video footage. So 25 years ago, nobody had a video camera at hand when somebody was having an episode, and now every human being on the planet has got a video camera in their pocket at all times, and so this massively helps us with making accurate diagnosis. And so we must consider non-epileptic seizures because they're incredibly distressing for children, young people, and their families, and because they're treatable. But as Morgan says, it's really important that we get the diagnosis right. 25 years ago, 30% of patients who were on medication for epilepsy had been misdiagnosed and, in fact, didn't have epilepsy at all. So 25 years ago, we had a big problem across the whole of the UK with epilepsy diagnosis, and I think that things are much better now, but diagnosis is really crucial. So with all of that, and with very high levels of very prevalent mental health difficulties in our patients, then you would expect us to be able to make referrals into services who would efficiently see those patients and to help to make them better. And regrettably, there has been a huge lack of kind of universal access to mental health services for children and young people in the UK. So it's been really difficult for children and young people with any kind of chronic health condition, or indeed solely mental health difficulties, to get help with their mental health. And in terms of the integration, which we use lots of words for, sometimes we call it co-location, sometimes we call it integration, but that idea of not sending people away for their mental health treatment, it doesn't make sense to children and young people that they're being seen by an epilepsy specialist for a brain problem, and they've got another brain problem, which is their mental health disorder, and they're being sent away to another place in the same town, the same city, or sometimes even a different town or city. And those two teams don't talk to each other, and there may be a lack of epilepsy expertise in the mental health services, and so that kind of disjointed mental health care just doesn't make any sense to anybody. But that's what we've been confronted with. So as I say, only 9% of pediatric epilepsy units have had kind of integrated mental health services when we've looked at this before. And the Epilepsy 12 audit shows us that we're making a little bit of progress with that, but it's very slow, and it's definitely not quick enough, because we need to be providing better care for children and young people.
Great, thanks, Richard. So for those who don't know, maybe you could tell us just really briefly what Epilepsy 12 is. Yeah.
So the Epilepsy 12 was the first iteration of Epilepsy 12 came out in 2012. So I think that's one of the reasons why it's got a 12 in it. And also it looked at 12 different criteria. So, how quickly children and young people could get access to MRI scans and to EEGs and the accuracy of their diagnoses, and whether they were put on appropriate treatment. And so it was really a national audit that looked at the quality of care. And it's really important when you're trying to improve quality that you've got some data that shows what the kind of current level of quality is, and whether you're making any difference to it as time goes on. And so that we're into the 6th round of Epilepsy 12 now. So it's been running for 13 years, and every epilepsy unit within NHS England and Wales contributes to that national audit. So it gives us, firstly, some really good data that we can use to try to drive quality forward, but also it means that we can see the trends over time. And I mean, it's nice to see that things aren't getting any worse, but I think that we would all look at the data and say that things are getting better too slowly.
And so one of those key things that you can look at in Epilepsy 12, if my understanding is right, is how integrated mental health services are within the epilepsy clinic. So how many, I suppose, psychology teams and epilepsy teams you have working together in one place. So.
Well, the granularity of the data for the last 13 years hasn't been able to show us that, but we are now asking more sophisticated questions about mental health, and it is giving us better data. I think that to give us a really, really good idea of what's going on, we're hoping that these NHS England pilots, which are actually, putting into place what would be a good standard of integrated mental health care, and looking at what difference that makes, then that will give us a slightly greater degree of detail. But yes, we're asking about the care of every single patient with a new diagnosis of epilepsy, and, for example, asking the question if the clinician that sees them in their appointments is routinely asking them about their mental health.
That's great, thank you. Ingram, I wonder if you can talk a little bit about your experience from your perspective, and also maybe talk a little about the impact. I know Morgan's already summarised this really nicely, but if you have any further thoughts on the impact of the lack of support, mental health support, has on the overall well-being of young people with epilepsy.
So Morgan's talked about that sort of long journey. It doesn't have to be a long journey, but it can be a long journey. And I think one of the things where we can improve is recognising the prevalence of the mental health challenges that young people will experience. Richard talked about a third, but depending on where you set the thresholds, up to 2/3 of individuals with epilepsy would experience some kind of significant mental health challenge that warrants support. And I think what Richard's pointing out, what we're aware of, is that everybody isn't asking questions about mental health. Not everybody feels comfortable beginning a conversation about mental health. Morgan talked about the benefits of talking about it, but you have to feel confident that the person you're talking to is going to listen to you, is going to be able to understand and respond to what you need. I think it's very difficult when young people open up about their mental health and they're not understood and they're not listened to. So training people, Richard, to understand mental health, to feel confident in asking questions about mental health, to feel confident about responding to mental health needs when they see it, is really important. I'm a psychologist, so often people are referred to me because somebody has taken the time and trouble to ask about mental health, and they've said this young person needs help. Perhaps, Ingram, you could see them in your clinic, and we're grateful to provide that service. But what we can't do is recognise needs in individuals who've never been asked about their mental health. So my feeling is what we need to do is to recognise it's a long journey for some, and asking about diagnosis, considering the impact of diagnosis. How are you feeling about taking medication? How are you feeling about the security of that diagnosis? We need to get the diagnosis right, as Richard points out, in order to deliver effective treatments. And the same goes for the mental health side. We need to be asking questions. We need to think about, well, what is this struggle that you're experiencing? How might we characterise it? And how can we get you access to the best support for you right now? And resources are an issue, but I think for some, very simple, straightforward, time-limited interventions can be really helpful. Not everybody needs 12 sessions of cognitive behaviour therapy. Sometimes talking to someone, attending a workshop, finding out that the experiences that you're having are common to many young people with epilepsy, and sharing those experiences with others can be a really powerful intervention. It doesn't have to take up huge amounts of time. So, I think it's about recognition. It's about the confidence of people around you to be able to respond to what it is that you need. like I said earlier, I think that you clearly, alongside your friends, were able to develop expertise around the management of your seizures. And I hope that the systems around young people start to develop that expertise around the management of mental health. Sometimes talking to parents can't always be easy. Parents, understandably, I'm a parent, it's not always easy to hear your children when they describe the struggles. So sometimes we can close down those conversations too early, or we don't feel skilled in responding to that. So some of the work we're doing, and I think is going on more widely, is supporting parents in being able to recognise and respond to the distress that they might see, or the mental health struggles that their children might experience. So that's again part of that puzzle.
You alluded to a couple of challenges in terms of why perhaps mental health support services aren't so available for young people with epilepsy. One thing you mentioned was perhaps people not feeling equipped to have these conversations. Do you think that exists in healthcare, with healthcare professionals as well?
I think it does with some. I think we're getting better at it. I think Richard and I are here because we're passionate about mental health and epilepsy, and so but that isn't the case with all of our colleagues, Richard. I think it's for some, they would benefit from some support around what does it mean to have that conversation. I've been struck by hearing from colleagues saying they worried that if they start a conversation about mental health, they won't know where it will lead, and they won't know where to refer someone, because as Richard points out, it's not always easy to get access to those mental health services. They might be in a different city, they might be in a different town, they're often separate from the epilepsy specialist centres. And so there isn't that security of a pathway from the initial conversation about mental health into getting the treatment. And so I think because of the lack of security around the pathway, we feel uncomfortable setting up an expectation we can't deliver on that. That's very disheartening, isn't it, for a clinician, Richard, to begin a conversation with a young person to identify they need something and then think, but I'm unable to help you with this. So I think as professionals generally, we tend to ask questions about things we can help with, and we tend not to ask questions about things that we know we can't help with. So the more help there is available in the system, the more professionals are aware of the help that they can access, I think the more confident they'll feel in beginning that conversation.
And I suppose maybe training in how to have that conversation is helpful as well if people don't come from a mental health background. Yeah.
I mean, training for, healthcare professionals, but training for teachers, counsellors at schools about, what epilepsy is and how it interfaces with mental health. I think some of the things that Richard talked about resonate very much with me as a clinician, that, there is a relationship between epilepsy itself. It's a condition that affects brain function, can sometimes be underpinned by differences in the structure of the brain. It can lead to conditions like autism and ADHD, as Richard's described. I think for some people, whether it's in healthcare or in education or in family systems, the focus can be very much on managing the seizures themselves rather than thinking about what's going on for you alongside this and what might be linked to the epilepsy. So we focus very much on getting the seizures under control, and that's important, and it's important for young people. But there is often a relationship between the frequency of seizures and the levels of anxiety. If we can tackle the anxiety alongside the seizures and not wait for one or the other to resolve, then I think we're much more likely to be able to deliver improvements in the health of young people.
That's great, thank you. Richard, I don't know. Go on.
There's a really interesting piece of research by one of my colleagues, Isabel Heyman, who's a neuropsychiatrist, and we use this a lot when we're trying to make an argument for better access to mental health support for children and young people with epilepsy. What she did was she looked at the quality of life of children and young people with epilepsy over several years, about 5 years. And what she showed was all that work that, as Ingram said, people like me do in trying to stop the seizures made very, very little difference to the quality of life of those children, young people. But if you look at their quality of life in terms of the support you offer them with their mental health and the any improvements that you can make to their mental health rather than their seizures, then it's associated with a significant and persistent improvement in their quality of life. So everything that I do at work, nearly completely pointless. Everything that Ingram does is incredibly valuable.
Thank you for that, Richard.
So that's incredibly powerful, isn't it? What we're trying to do here is we're trying to make people's lives better. And focusing on specifics like seizures and what the brain scan shows and what the EEG, it's all important parts of our work. But actually, mental health is crucial to people's quality of life. And so this is the real business end of whether people are, happy in what they do. So it's absolutely crucial that we focus on that. And as Ingram says, that we learn to ask questions better, and that we can find ways of helping. I can give an example of how we've done that a little bit where I work, because when I was the clinical lead for Pediatrics, then I set up a half-hour meeting once a week between my whole pediatric team and the clinical psychology team. And because I work in a teaching hospital, then the clinical psychologists, there's lots of clinical psychologists, but actually most of them are not accessible by children and young people with epilepsy. And most of them are not accessible for children and young people with kind of general pediatric issues either. But by bringing together those two groups, then you start to get learning from each other. And so, and now that we are trying to integrate mental health care into our normal care for children and young people with epilepsy, we bring those discussions to that meeting. So what I think we see over time is that all of us learn from our colleagues who have expertise in mental health, and we learn better how to ask questions. But also that by integrating into the sort of general pediatric team, everybody else is seeing how to better support young people with epilepsy. So we're basically just trying to make sure that mental health is a priority across all of physical health services, and obviously my focus is always on thinking about those children and young people with epilepsy. So I think that it's really important to integrate teams and to have to lose those artificial boundaries between the body and the mind, and just try and work at things together.
Yeah, absolutely. And I suppose that speaks to what you were saying earlier, Ingram, about more holistic care, so kind of treating all aspects of a condition rather than one aspect of a condition. I wonder if, I know you've alluded to it, Richard, in terms of the bundle of care work, but we've talked a lot about kind of the integration of mental health services in epilepsy care. And I know you were closely involved in the bundle of care as well, Ingram. So maybe you could talk a little bit about your experience of how that's been and where we are with that now and what the bundle of care is.
So bundle of care takes some great ideas, I think, that Richard mentioned that have been implemented outside of England. So our colleagues in Scotland developed a screening methodology called PAVES, which is integrated with this subsequent pathway around you ask questions about mental health, young people fill in questionnaires about the challenges that they experience, but there is a defined pathway for any professionals who are receiving those questionnaires around, okay, what do we do about this? And essentially we've taken that learning from colleagues in Scotland, and we've integrated in a small number of pilot sites, 7 pilot sites in England, a process via which we front end those conversations about mental health through using these questionnaires. So in Bristol, we've taken the approach of supporting our epilepsy nurses in having conversations about mental health. And initially they had understandable reservations, they're under pressure, they need to focus on a whole range of things, and mental health, although they recognise it as important, it's one of a number of things that they're under pressure to deliver on. But through the pilot, we experienced that we were able to support them, supervise them in a very similar way to the one that Richard describes in his teaching hospital. That when we got together, Richard, we were able to find ways that we could much more effectively support those at the front end to recognise and ask some sensible questions about what that young person's mental health needs were. What's been really interesting for us in Bristol is that we were quite worried about, well, when we start asking these questions, and if we're worried about 2/3 of young people having mental health problems, we're going to find that there is a need that's been identified that we're going to find hard to support. So we were kind of tried to get ahead of that, and we developed some groups for young people using a therapeutic technique called acceptance and commitment therapy. We can talk some more about that, but essentially the group allowed us to get young people together to benefit from conversations between themselves, but also with the facilitation of someone with a professional background in mental health. So we built our capacity to be able to respond to the needs that we identified. But I think what was most surprising, I suppose, about our experience of the pilot, and I don't know what Richard's experience has been, but what we discovered is, although we identified prevalent mental health problems, we were also much clearer about what form of help would be best for which individual, if that makes sense. So for some, the problems were around being frightened of having a seizure, or being worried about the medication, or having social concerns. For others, they were, complex anxiety and depression, and sometimes significant risk. But we were identifying far few young people with highly significant mental health problems, identifying relatively few with considerable risk, but a fairly large number who would benefit from straightforward advice and guidance around social issues, around emotional issues related to their diagnosis, or the impact of having a seizure at school, the social impact of that. And I think what this tells us is that we can respond in a fairly straightforward way that doesn't have to cost us a fortune, that can really help that child in that particular moment if we're prepared to listen to what their difficulties with epilepsy are. I mean, Richard's right that he's being generous to psychologists and saying what we do is useful and what he does is less useful. But I think we're all useful in this space, aren't we, Richard? So those conversations that are had at the front end by young people with epilepsy are not had by psychologists. They're had by nurses and doctors who are working with this. And we need to work with our colleagues like Richard to make sure that the simple, straightforward, cost-effective interventions are delivered in such a way that they're integrated in that front end. Not every young person will be able to see a psychologist, but the good news is that not every young person needs to see a psychologist, right? For some, it's access to digital tools, it's a website, it's a podcast, it's a conversation with another young person who's experienced similar struggles. It may be an epilepsy nurse who's able to give guidance around going on school trips despite having an epilepsy diagnosis. And if we can improve challenges around social integration, we can start to chip away sometimes at some of the factors that make young people with epilepsy vulnerable. So I think that this is how we can all be useful in that system.
So essentially, by identifying the specific challenges that a young person is facing, you can provide an intervention that's suitable for that specific young person, or maybe not an intervention, but something less intensive, maybe, like you said.
So we found, again, our experience was that we were getting a fairly sizable number of referrals from our colleagues, epilepsy specialist nurses and paediatricians, into our clinical psychology service. But the problems were not very well defined because the front-end conversation had been rather brief. It hadn't fully explored the precise mental health concerns. So we were having to do a lot of that work as psychologists. And while we were quite happy to do that work, we were not seeing the right people in the right place at the right time. And so I think that moving that conversation upstream, if you like, so colleagues like Richard, his colleagues in the nursing front are having a much more confident, well-informed conversation at the start, and they can identify young people who benefit from a specific intervention, whether it's a group or whether it's referral to CBT, whether it's referral to our colleagues in psychiatry and mental health services. And I suppose Richard's also right that we need to be having conversations with our colleagues in mental health services to say that there is also something about supporting young people having access to those more conventional mental health services that, yes, might be in a different city or town, Richard, but sometimes they are the best place for some young people with quite significant mental health challenges. That's not to say we should be referring everybody, into conventional mental health services, but in some cases they are the best source of support. And I don't think having epilepsy should prevent you from having access to other forms of support to which everybody else is entitled to. So there's work to be done on all of those fronts, sadly, isn't there, Richard? And we have come some way since 2012, but I would agree with Richard that progress has been painfully slow in some areas. But these pilots have been really exciting for those of us who've been involved in them, and we're starting to see a way forward that opens up a very, I suppose, innovative way of thinking about this problem.
Absolutely. I wonder if you can talk just a little bit more about some of these specific interventions that exist. So maybe not the conventional mental health services, but some of the specific ones that are epilepsy specific.
Yeah, so we've, in our groups, we've used, we've developed actually, RAU and Young Epilepsy have been very, very helpful in taking a relatively recent development in a form of cognitive and behavioural therapy called acceptance and commitment therapy, which we've adapted to be specifically addressing in a group setting some of the challenges that young people with epilepsy would experience. And acceptance and commitment therapy is essentially about recognising some of the things that are going on in our minds when we experience mental health challenges. So I was thinking about this morning, and I was thinking, I'm quite nervous about coming on this podcast. I don't know how I'm going to come across. I don't know whether my words are going to come out right. And so acceptance and commitment therapy is about taking, and it's a very rather silly example, but it's something that all of us experience, a degree of anxiety, that the more we're able to recognise how that feels and the thoughts that we have in our head, the more we're able to think about the choices that we've got to make about how we address those things. So I've chosen to come here today. I've made a commitment to come here today. I think it's important, Morgan, that we talk and we hear from you and we hear from Richard about what's going on in this space around mental health. And I've made that choice despite having butterflies before showing up. I mean, Morgan talked about withdrawing and kind of hiding away. Those aren't irrational things to do. If the world's a scary place, and when you go out into the world, whether it's socially or educationally, you experience challenges, it's quite a natural thing to do sometimes, to hide away from that. And I think what we're able to do through this group, through this methodology, this therapeutic technique, is not force people to make different choices, but just promote awareness of what it is that's going on for you when you choose to hide away, right? So how might opportunities be opened up for you to make different choices, some of which will be really hard to do the first time you do it, but the more aware you are of what's going on in your mind, the more you're able to make informed choices about what you really want in your life, right? So I wanted this podcast to be in my life, right? So I made a choice today. The challenges experienced by someone with significant mental health problems will be much more severe, pronounced, difficult to manage, and having someone else to talk to, whether it's another young person who's experienced similar struggles or a psychologist to facilitate some of that work, I think just enables you to develop some awareness of the kind of thoughts, feelings, experiences, behaviours that might accompany a mental health problem, and maybe think about how you can work with that differently. And I think you also start to draw other people. We talked about the importance of, friends and family and teachers and mentors and healthcare professionals in that space. But everybody has a responsibility to play a part in improving young people's mental health, and particularly young people with epilepsy.
Absolutely. Thanks, Ingram. So, Richard, I know you've also been closely involved in the mental health pilots. So I wonder if you could reflect on your experiences of them. Have you faced any specific challenges, or have there been any barriers, or what's gone well as well?
Well, so there's all sorts of aspects to that. So there have been definitely challenges with the pilots. So in terms of setting them up, then because the funding has been for 2 years, then one of the problems with that is that you need professionals with expertise to work within these pilots. They've got existing NHS jobs, and you're asking them to move into a job for 2 years where the ongoing funding for that is going to be a bit of a challenge. And so recruiting the great professionals that we need into those roles has been difficult across the UK, but those problems are not insurmountable. Once you've got the pilots in place, then you need a system for screening mental health. And one of the ways that this is done is with questionnaires, and often children and families are asked to access those through a QR code. So with their device, they'd take a picture of the QR code and it would take them through to the web link, and they'd be able to complete their questionnaire, and then that is automatically scored, and it gives a sort of red, amber, green traffic light result, and then that's sent through to a kind of a group inbox of an NHS email account for that particular epilepsy service, so that those professionals can see it. Now, just that simple process of being able to send out QR codes to people and then enable the results of it to go into a communal inbox that the epilepsy team can look at has got kind of governance procedures that are almost impossible to overcome. So like the NHS is really serious about its sort of data protection and information security, and it's been really, really difficult. But we're living in 2025, and this is definitely the way forward. So we have to try and move whole systems in that direction. So again, with a bit of time and effort, and by which I mean quite a lot of time and effort, then those problems are being overcome, and young people are being screened. And then you're in a nice conversation with young people with good information. You've got a nice red, amber, green scored result, and then you have to try and find support. So then it's been necessary to build those links within the individual teams into appropriate mental health services, which are hopefully integrated. But as Ingram says, there's always a menu, isn't there? There's kind of universal services, and sometimes that looks a little bit like signposting through, again, usually other QR codes into other kind of helpful universal services. Sometimes group projects like getting together a group of young people with epilepsy and providing some support and enabling them to meet each other, and sometimes some specific work by experts using techniques like the ones that Ingram has used. So all of that is a culture shift. It's a change in practice for many practitioners within the NHS. But once you've put it in place, then it's the new normal, and children and young people benefit. Absolutely. I was going to use the word rival, but that's the wrong word to use. But PAVES was done in Scotland, and the Great Ormond Street team did a very good project called MICE, Mental Health Intervention in Children with Epilepsy. A really very similar idea about routinely screening children and young people for their mental health difficulties, and if they hit a certain threshold, then providing an intervention. Their intervention was called the match intervention, and I think there was an average of about 16 different contacts from a mental health trained professional who in that study, they were all clinical psychologists, but the idea was that it didn't have to be, and basically through almost a manual of intervention, then those children could be tried to give some support. Excitingly, they've looked at cost effectiveness there, because the NHS is always interested in whether things will cost lots more money. And it won't be a surprise to anybody working in the field that if you improve the mental health care of children and young people with epilepsy, then they cost the NHS less money. So, for example, there might be better adherence to treatment, and they might come to the emergency department less with seizures, and that saves the NHS money. And so what the MICE study showed was that all of this actually ends up being cost neutral. Okay. So, that's incredibly powerful. It hasn't led to the NHS leaping into throwing money into these services yet. but of course that it's going to be important to show that this needn't cost the that it needn't cost the earth.
Yeah.
And I think that as Ingram says, when professionals are sitting in a room with a child or young person and their family, asking about mental health when it hasn't been raised as an issue can sometimes feel a bit awkward in kind of the general pediatric context. But I think our experience of the pilots has been that bringing this into routine practice has been nothing but welcome. Nobody says, I think it's appalling that you're asking about my child's mental health, or I can't believe you're asking me about my mental health, doctor, because actually everybody recognises that having a chronic illness and having seizures comes with it emotional difficulties, social difficulties, and often other significant mental health problems. So basically asking it always goes down a treat.
Fantastic, thank you. So all of the work that's going on in this pilot sounds fantastic, but I assume that they're time limited, so they're funded for a specific period of time. So what do you think about the continuation of these? How do we think that we might be able to do that? Richard, do you want to start?
Well, so it's a really interesting question. How might we be able to do that? And the obvious answer to that would be to say, right, okay, well, we understand the rules of that particular game, and we will relentlessly follow the rules of the game, and then good things will follow. Money will fall from the money tree, and that we will put into place some fantastic services for children and young people with epilepsy. So one of the things that I've come to recognise over about 9 or 10 years of working at a national level in quality improvement in this area is that there's no pattern, there's no rules of the game that you can follow that will inevitably and surely lead to that sort of thing happening. But I think that kind of like relentlessly going on about it is very valuable. Raising the visibility of it is incredibly important, and we just have to take things step by step. So I think I've come to terms with the fact that we're not going to get universal access for mental health services for children and young people with epilepsy in the next 2 or 3 years. It's going to take much of the rest of my career, but we just need to be relentlessly on a program towards getting there. So visibility is incredibly important. I've presented at an NHS England conference that was about sustainability of these projects. So it's really trying to focus exactly on the question you're asking. Okay, so we put these pilots into place. They're running for 2 years. What happens next? How do we get the ongoing funding for those pilot projects, and how do we then roll them out across the whole of the country? I do think that all of the different NHS England systems that are involved in this are keen to improve quality. So the children and young people teams at the integrated care systems, which is the kind of groups of hospital trusts within the NHS England regions. So, for example, in my region, which is the Eastern region, there are 6 integrated care systems. And within the integrated care system that my hospital works in, there are 3 hospitals and some community trusts as well. So across those integrated care systems, there are people working to improve stuff for children and young people. And they're all really enthusiastic. But of course, they don't have access to huge amounts of resource. The board level interest in epilepsy is increasing. So I think it would be fair to say that 10 years ago, epilepsy was a largely forgotten area at sort of senior levels within the NHS. But I think we've made significant improvements in that area. And for example, NHS England documents now contain the words, epilepsy, diabetes, asthma for children and young people, which, 10 years ago they never did. When you look nationally, then there's clearly interest in improving mental health services for children and young people across the board, not just in epilepsy, but for many different services. So I've heard it said, we think we're 26% of the way there towards, which is a remarkably precise figure. But that's good that there's kind of awareness at a national level that there is much work to do, and indeed resource that needs ultimately to go into children and young people's services. One mistake I think that many people within my profession sometimes make is to look at diabetes and to say, all we need to do is what diabetes did, and then we will get the same kind of huge investment and particularly routine access to psychology that the diabetic services did. And that argument just doesn't wash nationally, right? People are not interested in the discrepancy between what children and young people with diabetes get and what children and young people with epilepsy have access to. So we can draw comparisons all we like. We've been drawing comparisons for a decade. It doesn't work. We have to congratulate the diabetic team, 15 years ago on doing some brilliant work with securing resources. And we just have to keep doing our best to try and get parity for children and young people with epilepsy. But the comparison just doesn't help, unfortunately.
Great, thank you. So basically, visibility, keep kind of banging on the door and making people aware of the issues and that they need to be solved. I suppose another aspect is you were talking a little bit about this in context of the MICE intervention, the mental health intervention, is demonstrating success and demonstrating why it works in a number of different ways. Ingham, I don't know if you could talk a little bit about how we can measure success in these pilots to try and convince wider NHS England or NHS teams that it's a worthy investment.
Well, Richard's talked about some ways that we can measure success. So one way, a particularly impressive way, particularly with regard to sustainability of some of these interventions, is demonstrating it doesn't cost hugely more. In fact, it's cost neutral. And Richard's referring to cost neutrality in a very narrow time frame. If we think about the benefits in terms of your lifelong cost benefits of avoiding significant mental health problems in childhood, they are tremendous in terms of the potential lifelong cost, Richard. So the savings are often, way beyond the sort of confines of any study around cost effectiveness of an intervention like MICE within, say, a 2-year period. I think there are changes we've made recently which would be very hard to reverse. Richard's talked about how difficult it was for him to get a QR code in an email. I think once those things are implemented, sometimes they're quite hard to take back out of a system. So I think I don't want to commit our epilepsy specialist nurses to this, but I suspect that they will continue to have conversations with young people about mental health needs, and they will continue to screen a much larger number, Richard, of young people for those difficulties. So I think that there are some changes. The phrase I think that is used now is baked in. There are some changes that have been baked into the system. I think there are other things that do cost us time and resource, like running the groups, referrals to psychologists and to CAM services. This will require investment in those services if they are to continue to be provided. I think Richard's right and much more experienced in this space. We need to be having those conversations relentlessly, don't we, with people who can make decisions to fund those services about just how effective these pilots have been. But they've been effective in a number of ways. We talked about the need for conversations about mental health being much more common. We need to screen young people, children and young people, for mental health problems much more effectively, because we otherwise will not recognise those mental health problems. I think that, like I said, I think some of those things will be hard to reverse. I think there is a need for investment. I'm glad we've got to 26%, Richard, and hopefully next year we can add another chunk onto that percentage. But I agree with Richard. I think it's not something that's going to be solved in the next 6 months. I think there may well be some things that pause after a PIA, to pause for reflection. But it's also a time for, as Richard says, for us to use our voices as professionals and make sure that people are listening. I think Richard's right about diabetes. One thing that I would say is I think one of the things that's been great about the pilots is we've got a different model for epilepsy, Richard. It's not the same model, but I don't think it's a worse model. In fact, I think it might be a better model. I think we understand the relationship between seizures and epilepsy and mental health and other diagnoses like ADHD and autism spectrum disorder. We know there are pressures elsewhere in the systems around getting access to those diagnoses and corresponding treatments, and that's no different for young people with epilepsy. If you haven't got an ADHD diagnosis, you're unlikely to get treatment and recognition of your ADHD. So we need to make sure that we also focus on making sure that the accuracy and the access to those diagnoses, Richard, is something which is also on the table for young people, because that's a considerable challenge. So there are areas other than the pilots where we need to do additional work to kind of bolster what we're doing in mental health in a sort of holistic sense. The other thing
I think the ADHD question is really interesting, because this is almost phase 2, because so we're piloting, screening for mental health issues and intervention, but we're not really screening for ADHD.
No.
Now, the reason why this is almost like a kind of a particular case all in its own is that ADHD is much more common in children and young people with epilepsy. And there was a really good study called the CHESS study, which showed that ADHD was very significantly underdiagnosed in that population of children and young people with epilepsy. So for every one patient in that study who had a diagnosis of ADHD, there were 2 patients who met the criteria for having a diagnosis of ADHD but didn't have the diagnosis and therefore weren't receiving treatment. So massive underdiagnosis. But the really important thing about that is that we know that treatment of ADHD is important in improving future life chances. It's important in improving quality of life, and it's cost effective. Yeah. So there's we're working on kind of more common, but we're working on more common problems at present. But at some point in the future, then ADHD is a really good archetype for a diagnosis that we need to be looking for. We need to be essentially routinely screening for that, and also then we have to have services in place that can look at treatment. So if that's going to be medical treatment with medicines, then you need professionals who can do prescription and who can monitor treatment going forward. So ADHD is a really interesting thing, because we've sort of started the ball rolling with improving children and young people's mental health, but we can see that over the next step, then the ADHD is going to be a really big issue. And I was hoping I could provoke the mice team into doing mice 2, which would be sort of ADHD screening and intervention. But I don't think I made my case well enough. But yeah. So even when Ingram and I have cracked the nut that we're trying to get into at the moment, we've got other nuts to crack in the future. So this will take me well into retirement.
I suppose what I would say, Richard, on that, because you made the point earlier, what we don't want to happen is for, in the spirit of integration, what we don't want to do is for young people with epilepsy to meet one person for their epilepsy, another person for their mental health problems, and yet another queue to join to get an ADHD diagnosis and corresponding treatment. There needs to be a level of integration of these different aspects of care, such that it isn't just a series of different queues that you're moved from one to the other, because people will wait a long time, won't they, to get to the end of those queues, the front of those queues, and to get the diagnosis. My hope is that we think about epilepsy, autism spectrum disorders, mental health problems as being interrelated, and the expertise being integrated into those systems that are looking after the seizures and the medication for seizures, should also be able to deliver decent screening for not only mental health, but also common comorbidities, Richard put it earlier.
Absolutely. So for the young people or the families listening, all of this sounds really exciting, but how would could they access any of this work? What would you recommend for them in terms of how they could get involved or access mental health support? Richard, do you want to start?
I think what we're saying is that ideally that mental health support should be integrated with their epilepsy team. Obviously the most important point of contact with an epilepsy team is always the epilepsy nursing service, and we know that contactability is one of the most important factors in any epilepsy service in terms of whether that service is perceived to be offering high quality care. So I would always suggest that if there are concerns about your child or young person's mental health, I'd always suggest that the first port of call should be contacting the epilepsy specialist nurse, because that's incredibly important in terms of signposting to universal services or offering services that are particularly integrated with that service.
Great, thank you. And do you have any other advice that you'd like to offer young people who are struggling with their mental health and epilepsy?
I think I don't want to embarrass Young Epilepsy, but I think looking at websites, looking at the information that's out there with some excellent resources online, and that will give you some guidance and support, and hopefully give young people, parents, families, confidence to raise these issues in conversation. I think I'm sure, Richard, if people ask and say we would like to discuss our concerns about mental health, or if that's something that young people proactively bring to clinics, I think it's then incumbent on those professionals to listen and to take note of that. It might feel like a brave thing to do, but I think we've educated the system, Richard, to the point where you will find that there are receptive people prepared to have that conversation, and we'll be doing favours for everybody that follows in terms of making sure that those conversations are had front and centre in epilepsy care. So I think that yes, while we await the funding and that 26% to grow, Richard, in terms of how close we are to solutions, I think we've begun a conversation that's been really important, and this conversation today is part of that. And I would urge young people to talk about it, to open up those conversations, to say that I would like to talk about my mental health concerns. I'd like to talk about my well-being. I wonder if it's something we can find space to talk about today. And you should find, anyone that you're talking to in the healthcare system receptive in that regard.
Great, thank you. I wonder if we can finish one last question about what you're most excited about in this space in terms of the work that's going on, or what you foresee for the future. Richard, do you want to start?
Yeah, so I think that the pilots are sort of coming to fruition now, and we're going to start hearing those presentations of their data and what they've learned about putting the pilots into place within their integrated care system. And I think I'm very excited about taking those results to the CYP teams at NHS England and saying, right, okay, what's our next steps? So there's sustainability of those projects, and then there's trying to put such processes and teams and improvements in place in more hospitals, and eventually in all hospitals that look after children and young people with epilepsy. So I think that's incredibly important. I'm looking forward to the MICE team publishing some more of their data, including their sort of cost effectiveness data. So I think that's going to be a really important lever for us to use nationally, so that we can try and secure better things for our patients. I think then we go on and try and crack the ADHD nut.
Thank you. Ingrid, is there anything you want to add?
Yes, I think that I suppose I'm excited about what comes out of these kinds of conversations, because it's all very well for psychologists to talk about mental health issues. It's really inspiring to hear others, grasping these batons, Richard, and taking them forward into much broader spaces. It's not surprising that clinical psychologists are concerned about mental health. It's really, I suppose, enlivening for us, inspiring for us to hear other people taking mental health problems really seriously and taking those conversations to places where we might start to see some change happening. I'm inspired by hearing conversations like the things that you've brought today, Morgan. That I think it's not easy having conversations from a position of personal experience, and I'm sure there've been challenges along the way. I think that young people themselves are driving this conversation, Richard, in a way that is humbling to watch, because I think it's not an easy thing to do. And I think, again, it's presenting a challenge, isn't it, to our establishment view of how epilepsy should be treated. And I think it's really exciting to see that dialogue changing quite significantly.
Absolutely. And Morgan, I don't know if there's anything you've heard that particularly excites you, or if you've got any thoughts on any of the things that we've spoken about.
No, I was just glad to hear that there's more things coming, that there's more change coming, that there's less budget constraints than I thought there was. I was glad to hear about the cost, that it's actually cost neutral, and that in the long run, as you said, that it actually probably will end up paying out maybe even better than that, because obviously it pays very well to invest in mental health very early. I thought it was all really great to hear, and I hope that people will really listen to this information, and it'll be more implemented, and that more good will come out of it. And that's all I have to say.
Fantastic. I think that's a great place to finish. So thank you all so much. It's been great to have you all on. Thank you. If you or someone you know is struggling with mental health alongside epilepsy, there are services and resources out there to help. You can check the show notes to find out more. I'd like to thank all of our guests today for their brilliant contributions. As we wrap up, it's clear that mental health is a priority for epilepsy care, and while there are still challenges to overcome, the future looks promising. So thank you for tuning in to today's episode of Young Epilepsy's podcast, and a special thank you to all of the health professionals listening. Your work makes a big difference. Don't forget to subscribe and follow us on social media, and we'll see you next time for more conversations that matter.
Together we create possible.